Welcome, everyone. My name is Tim Moriarty, and I am a member of the board of the National Council on Interpreting in Healthcare, and I will be your moderator today. Today's discussion will be about how to develop a language access plan as part of the NCIHC On The Road webinar series. We're very glad to have you here today, and we have some exceptional panelists. We are going to wait just 1 minute because people are still logging on. So if you can hold on for just a minute, we will get started at about 1 after. All right, well, that was fast. So let me introduce the panelists. You've received a brief but longer version of the bio for each of the panelists today, but I did want to highlight their expertise because they all have incredible experience and will add so much to this discussion. Darcy Graves works at the Centers for Medicare and Medicaid Services, the Office of Minority Health. As part of her role, she provides subject matter expertise in areas such as culturally and linguistically appropriate services, rural health, cancer, health disparities, and health equity. She has over 20 years of professional experience in advancing the provision of culturally and linguistically appropriate services. Welcome, Darcy. Elida Acuna Martinez is the Senior Director of the Interpreter Services and Patient Advocacy Departments at the East Boston Neighborhood Health Center. Prior to the health center, Elida worked at Massachusetts General Hospital and Boston Medical Center, where she held various roles in the Interpreter Services departments. She has over 20 years of experience in the medical interpreting and translation profession. Fabian Armijo was born and raised in New Mexico and has worked at the University of New Mexico Hospital since 2015. At UNMH, he has served as a qualified medical interpreter, an interpreter trainer, and currently as part of the leadership team. In his current role as Executive Director of Diversity, Equity, and Inclusion, Fabian oversees the following areas: interpreter language services, community engagement, Native American health services, DE&I, education, and health literacy. And Monica Serrano is the Equity, Inclusion, and Diversity Language Access Manager and ADA Civil Rights Coordinator for Kaiser Permanente Northwest. She has over 20 years of professional and volunteer experience working with limited English proficient people in the Pacific Northwest. She has worked as an independent medical Spanish interpreter for Multnomah County Health Department, and later as a staff interpreter, translator, and supervisor for Oregon Health and Sciences University's Interpreter Services Department. For the last 10 years, Monica has been a leader for Kaiser Permanente Northwest, managing and building language access services. So as you can see, they're all real novices in the field. Thanks, everyone. It is such a pleasure to bring together such an experienced group of people to talk about language access plans. And I'm going to kick it off with just a simple question. What is a language access plan? Darcy, why don't you go ahead and start us off?
Absolutely. And thank you for those kind introductions, Tim. As he said, my name is Darcy Graves, and I work at the CMS, Office of Minority Health. All the opinions I share today are my own and don't necessarily constitute any kind of written direction from the Centers for Medicare and Medicaid Services. But to the question at hand, well, and of course, good morning and good afternoon, everyone. I'm loving to see all of the locations in the chat coming through. It's great to see the breadth and depth of this audience. So to Tim's question, and obviously a great place to start is, what is a language access plan? And in technical terms, or if you're looking at a strict definition, a language access plan is a strategic document developed by organizations, particularly in this case, healthcare institutions, to ensure meaningful access for individuals who have limited proficiency in the dominant language of the region. So we typically refer to that in most places in the United States, we're usually talking about limited English proficiency. But obviously that can differ depending on where you are regionally, and all of those things. And we'll get into all of those different bits in a moment. But while I have the virtual microphone, and before I hand it off to all of these esteemed colleagues who have such rich histories and lived experience in this work, I just wanted to talk about a couple of pieces that are included in language access plans, because I think that can kind of help people orient to what it is, because they're like, oh, it's great, it's a plan. And if any of us have worked at organizations, you know, there are a lot of plans, and there's a lot of plans that end up on shelves and people don't come back to it necessarily. And that's not something that we obviously encourage when it comes to language access plans. They're really living, breathing documents that help an organization meet the needs and provide meaningful access to all of those that they serve. And it is making sure that you are thinking about it proactively before individuals who are in need of language access arrive at your facility, at your organization. There's going to be a lot of different pieces that we'll talk about today because, and part of my background, I worked with closely on the development of the national class standards from 2013. And one of the things we always talked about is the national class standards are written in a way that they can be adopted by a hospital in Manhattan, a clinic in Des Moines, Iowa, or a community-based organization in Oakland, California. And that's the same thing with language access plans. No two language access plans are going to look alike because everyone is coming at it differently. Your communities are going to be different. Your needs are going to be different, and the needs of the people that you're serving are going to be different. So all of those influences, and I know Monica and Fabian and Alida have all sorts of examples of how to bring all of this richness to life. But some key parts of a language access include identification of language needs, so a needs assessment. Who are the number of individuals with limited English proficiency in your area? How do they contact and where do they contact your organization? What's the level of interaction? And how do you engage with those in your service area? You know, how do you engage with stakeholders? And it's not just how do they make an appointment, but it's how do you advertise that your facility exists? How do you advertise that you offer maternity care or cancer care or any of the types of specialties that your hospital or organization might do? The next part that's typically included in a language access plan is talking about the provision of interpretation and translation services. And I think everybody on this call knows, but interpretation and translation services are two different things. They're two different professions and they're two different skill sets. And I will leave that there because my colleagues on the call are much better equipped to talk about those things. But I long ago promised that anytime I was passed a microphone in talking about language access, that I would always issue that public service announcement that if you're watching Grey's Anatomy and they page a translator, that is wrong. Because no one needs a document translated that quickly. What they're looking for is an interpreter. Speaking of those things, notices, I speak cards, patient rights, documentation, taglines, and signage, making sure that the information is in, you know, in the languages, again, in the communities, making sure folks talk about staff training, making sure folks are aware that you have a language access plan, that they know how to call an interpreter or request translated documents and all of those pieces. And then, and making sure that, you know, it's not just the front line, it's not just the providers, but it's everybody who may interact with an individual with limited English proficiency, or I would say, in an homage to our ASL interpreters on here, you know, making sure that even if somebody is looking for deaf and hard of hearing or an ASL interpreter, that, you know, people in the parking garage may need to know how to access language services and those sorts of things. So it's a broad thing. So it's important to think about all the points of contact for your organization. And then finally, doing on, this is a QI effort just like any other QI, quality improvement, sorry for the acronym, quality improvement effort. So doing ongoing assessment and improvement processes, monitoring complaints or suggestions, making sure that your complaint process is linguistically appropriate. Can't tell you how many aha moments I've had over the years talking to people about those things. They're like, well, we never receive any complaints. And I say, is your complaint process linguistically accessible to in multiple languages? And then you get that blank stare and then the light bulb goes off. Keeping current on community demographics, populations change. Those in your service area, there can be evolutions of languages. Languages move in, languages move out. It's not, you can look to state level data because sometimes that's what you have access to, but know that that can vary widely if you're talking about a much smaller area. And there's probably 1,000 case studies about that. But with that, I will mute myself and offer Tim or any of my other panelists a chance to chime in as well. But thank you for letting me just kind of lay the groundwork for what we're going to be talking about today.
Great. Thank you so much, Darcy. You would be an incredible free diver, I think. I don't know that you've taken a breath, but the reason is because she is such an advocate of language access. Darcy has actually been partnering with NCIHC for many, many years in different ways, and we're excited to have her back today. But for those of you who may not have a language access plan or a small community clinic, and you're like, whoa, that's too much. What am I supposed to do? Let me do a quick summary of what Marcy just talked about. And we will share links to information because you don't have to start from scratch. And basically, what Darcy was talking about is having a needs assessment, talking about and planning for language services, providing notices, providing training, not to the interpreters, but to the hospital staff. What is it that they need to know to be able to do their jobs for people who have limited English proficiency and or are deaf or hard of hearing? And then the evaluation piece, as she said, oftentimes people kind of think in one dimensions and don't realize that English is only one of the languages. And if we're providing interpreters, we probably need tools, assessment tools in other languages to make sure that we're actually reaching the people who come to our facilities, but also the people who don't come to our facilities, because that's also an important part. Are there groups in your community that are not coming to your hospital or your facility for a reason? Perhaps it's because you don't provide an interpreter for their language, or they don't know that you do. Great. Would someone else like to chime in on that? I know it was a lot. Darcy provided an exceptional foundation for our discussion today. If not, I will move on.
This is Monica.
Go ahead, Monica.
I think with that, I want to also highlight that this plan is all about health equity. So when we talk about health equity, we're looking at social determinants of health. So we're looking at a population that oftentimes may not have yet developed that sense of I have a right to have the ability to communicate. So when we're looking at navigation and looking at what are the complaints, sometimes our patients who most need that service may not complain because there's a sense of fear. There's a sense of this is not what I deserve. And so part of that training too is really helping our staff understand that part of our work is to support the individuals so that they understand they have a right to this service. And this is about health equity. This is about helping them get to their best health. And in order to do that, they need to understand the information and in that process, helping them understand their rights and helping them understand that they have the right to ask questions and complain if they don't get the services they deserve in the language they prefer.
Great. Thanks, Monica. we talked a little bit in planning for this about the legal requirements for a language access plan. So would somebody like to talk about whether a language access plan is required on a national level? You may have some requirements in your local city or state, but is it required on a national level? Anyone? We spoke yesterday about how the plan itself isn't necessarily a requirement on the national level, but it's a really great practice to have. But what it does is it pulls together all of the other requirements. And we are required to provide language access. And if I may share my screen just for a moment, and I apologize to anyone who is deaf and working with the American Sign Language interpreters, I'm going to briefly, I believe the interpreter may disappear just for a moment, and I'll bring it right back. So if you are not familiar with the laws that are in place that require the provision of language access and interpreter services, these are the federal laws that really are the backbone to providing language access for spoken languages, but also for signed languages, and the provision of assistive devices under the ADA. But then it's also important to understand that there are professional standards, industry standards. The Joint Commission has standards about providing language access to our patients. The ANCC, American Nurses Credentialing Center, the organization that provides magnet status for the hospitals, also has language access requirements. And then there are state laws and regulations from those state laws that require language access as well. And so although the plan itself may not be required under federal law, the components are. And let's talk about the benefit to having a plan pulled together. Does someone want to take that? Fabian, perhaps?
Thanks, Tim. And good morning and good afternoon to everybody. And I think it's very early in the morning in Vietnam. I see somebody joined us from there. I think it's like 1 in the morning or something. Yeah, I think, one of the things I wanted to mention after my colleague Darcy spoke about language access plans is, it's important to have multiple plans too, to meet different communities' needs. I say that because at UNM Health, we have a team of in-person staff interpreters. And, we also have our interpreters who work at a call center type environment, and they provide language services to our patients. And we also have contracts with local agencies to provide in-person sign language interpretation. Important that people understand that, somebody who has low vision and is also deaf needs an in-person interpreter to provide tactile interpreter services. And one thing I just wanted to mention is thinking about that, working with your local deaf community, including them in the process. It's important that when we say somebody is deaf, that we don't just get an American Sign Language interpreter for them. So there has to be resources and knowledge around the diversity of deaf people and what we need to do to provide the kind of care that they deserve in our institution. So multiple plans or multiple sections of that plan that include as many people as possible. And who should have a plan? Everybody should have a plan who's providing a public service to your community. So I think of nursing homes and schools, and I saw in the chat that there's somebody who's working on getting their plan approved at their school. So that's fantastic. In healthcare, it's really important. And we're here to talk about that today because we understand when people are sick or when people are in pain, or they're out of their comfort zone, that they are able to understand and communicate with the people taking care of them. And there are big risks if you don't do that for people. And I'll talk a little bit about that later, what happened to UNM Hospital back in 2004. But anyway, I hope that answers the question, Tim, and thank you everybody for joining, and I'm happy to be here with all of you.
Great. Thank you very much. Does anyone else want to comment on that question? All right, so we will move on. we will provide a link as to where you can find, and I believe Darcy kind of commented on it. You don't have to start from scratch. There are outlines. CMS has a great plan for you that you can use as a basis for starting your own. And it will either get posted in the chat, or we'll make sure that we'll follow up with you about it. Let's see. Right. So the next piece is really about training. So we talked earlier about how it's one thing to have a plan, and Darcy talked about lots of plans. People have lots of plans that get shelved, right? And nobody looks at them. Now they're all filed electronically, but still people may not look at them. And so members, what do you have, what do you suggest for making sure that staff are aware of the plan and know that the information is correct? In what form, how often, etc.? Elida?
Hi, everyone. Thank you for having me here. Like it was mentioned before, my name is Elida Cuna Martinez, and I manage the Interpreter Services Department at the East Boston Neighborhood Health Center. This is a community health center, is one of the biggest in the United States. And I wanted to mention that because my challenges may be a little bit different than what you guys have, being in charge of bigger healthcare systems. And another important thing that I also wanted to mention is that although we are a small health center, 70% of all the patients that come to our health center are considered to be LEP, limited English proficient patients. So we have a huge number of interpreting requests that we complete. I wanted to highlight that before letting you know that it is very, very important to keep everyone trained at every level. So I was able to manage to go into the new employee orientation. So every employee that gets hired at the health center needs to go through the new employee orientation, even if they're just contractors, or if they're per diem, they go different hours, but I made sure that I'm at every single presentation when they come, when a new employee comes and joins the health center. I present a little bit on the language access plan, why it's important, why is it implemented in all the regulations in the Joint Commission standards, Department of Public Health standards that we have to follow. And I also have a part on how to best partner with interpreter services, because it's not just, you have an interpreter and you work with the interpreter, and I give guidance as to how to best work and partner with interpreter services. So we are considered part of the team and not just an extra person that it's there invading everyone's privacy, right? I also talk about the feedback on how to provide feedback to the Interpreter Services Department on any part of the language access plan part, where that feedback should go, and why it is important for us to get the feedback. So that's kind of like the first thing that we do at the health center. Everyone does not get hired through the same tunnel. So providers are hired through the staffing office, and providers are considered to be at the health center doctors, nurse practitioners, and physician assistants. So they get hired through the medical staffing office, and they don't go through the same orientation because they have a longer orientation. So I make sure that I'm there all the time as well. And in that sense, I provide a one-on-one training with new hires. It doesn't matter if I have to do it 10 times a month. I'm there. Make sure that I'm always there. I provide the same presentation that I provide to the new employees, to the rest of the staff that it gets hired at the health center. If I'm not available, I make sure that somebody else is available. And in that case, that would be the manager of interpreter services. We also have a cultural competency training that we do on an annual basis, and that is done through the Diversity, Equity, and Inclusion Committee, which I am also part of. I was a key part on obtaining and partnering with a vendor that we work with, and they have a very comprehensive part on language access plan within the cultural competency training. They have a very huge part on cultural humility versus what's cultural humility versus cultural competency, and why it is important to tie it to language access. And that's basically the training that we provide. The cultural competency training has to be taken every year. We used to have a very small part on how to reach out to interpreter services, how to best partner with interpreter services on a yearly basis, but this more comprehensive cultural competency training took over. And I'm very happy about that, because we do have to take it on a yearly basis. And it's not like you just slide through everything. You get questions, you get a test after, and it's different. Again, because we partnered with a vendor, they know what tests somebody took the year prior, so it's a different set of questions that they provide on a yearly basis. So that's the training that we provide.
Great, great. Thank you, Elida. Monica, did you want to chime in here about training? I know Fabian has been a
Thank
trainer
you.
before, so he has ideas. But any thoughts you would like to share first?
Thank you, Monica Serrano from Kaiser Permanente. So building on what Elida just shared, in our organization, KP Northwest, Kaiser Permanente Northwest, we have online training. We have different ways of doing that. We have training that people take, so that we're also documenting interpreter services at time of care. So that also includes what modalities of training do we offer, and when should we choose the different modality of interpreter. And of course, that includes in-person, video, phone, and that is very much determined by patient need and encounter type, and language availability. We know that there's some languages that we don't have available in person, we may not have. So then we may default to video or phone, which provides us a greater diversity of access to interpreters. That means in our organization, we have 91 languages that represented within our membership. So that means that we need to really be prepared to meet their needs. And as Darcy had said, we have to think about the whole journey of where patients might need services. So part of that is ensuring that we have the equipment, phone, video if necessary, so that we can readily provide that service. An important part that many people might not think about is the parking lot, which Darcy mentioned. That's the initial part where patients come, and that's already causing some stress and a patient getting lost. Having the parking staff with a phone to readily say, how can I help you, and direct, that may be the initial point of access. So thinking about where patients may need direction, support to get to where they need for that consultation, that may be so important. So
and how do you include that in the training, Monica?
It's within the webinar that we have. And I also, as Elida, do trainings in different departments when the need comes, so that we're really looking at how to support patients in the various areas where they might be. So
Thank you.
Do you mind if I jump in?
Go ahead, Darcy.
Sure. Thank you, Darcy Graves again. Yeah, I think it's so important, because when I think about when I go to a hospital or I go to a healthcare facility, sometimes figuring out where to park, then finding the front door, and then finding my doctor's office or the radiologist or whomever within that building can be the hardest parts of the journey for me, and English is my primary language. So I think part of it is that framing piece, especially if you have a complex facility. And it's not just the parking garage, but it's also the bus stop that might be out front of your facility, making sure that folks can get from A to B. I just want to, I started out my career teaching at a medical school, and so I had what I will refer to as a lot of reticent audience members when I talked about training and education. And so I think as we're talking about this framing and we're thinking about all of these different pieces, it's also figuring out how to do the training for our audiences and what messages resonate with that. You know, we talk about cultural competency and providers being in line with our patients, but we also have to make sure that we're in line with our providers so that they're hearing the messages that we're trying to deliver. So thinking about language access not only as a patient experience piece, but also as a patient safety piece, as a risk mitigation piece, as a patient autonomy piece. Like, there's all of these things that are so central to the tenets of do no harm, you know, because I think we not that any of these individuals are on the call today, but sometimes people, you know, the term health equity doesn't resonate with everyone at the same level that it resonates probably with myself and my fellow panelists. So figuring out how do we communicate the import of this work with all of the potential audiences, because, you know, when you talk about understanding and you talk about patient autonomy and you talk about risk mitigation, it's really hard for anyone to argue against those things. So just as we're thinking about framing and we're talking about training, making sure that we're capturing all of the spirit that is involved with the language access.
Right. And I think a great reminder that it's not just the communication piece, the information piece, it is the patient safety. And we see this every day. Someone goes in for an x-ray and they're about to x-ray the wrong elbow because that's what the electronic order says. But the patient knows better. And with the assistance of the interpreter, they can clarify that and challenge that. And, you know, you never want to get the wrong foot or leg taken off because of a diabetes diagnosis and it being marked incorrectly, or the provider, the surgeon, not realizing where they had done their initials, right? The interpreter sometimes is the important piece there to verify. I also was thinking, as we're talking about training, we all learn in different ways. And certainly in today's educational system, we know that some children do better visually, some people do better with text and so forth. So I think that's another thing to think about. How are we reaching them? And is it only one and done? Or are there a variety of ways that we touch staff members to make sure that they're understanding the message? Do we have reminders every once in a while? Is it over our internal TV systems or something like that that will be, oh, yes, that's right, I should do that, or I absolutely have to do that. And also, many of our facilities are training facilities for people at different levels, rad techs and MAs, but also nurses and doctors, and to think about gaining access to their schools, or if we're a site where they come to learn, to make sure that we are meeting their needs as well and participating in their training. I'm going to go to Fabian first, and then I'll come back to you, Monica, okay?
Thanks, Tim. Yeah, I think, you know, it's once we've got our language access plan, we've got to make sure that people know that it exists and how to access it. Because if people don't know the resources there, they might not use it. So I think in a big health system like UNM Hospital is a part of a larger health science center and health system, different people get different onboarding. So Elida mentioned about the NEO, new employee orientation, that she's a part of, and that's important. And we do that in our hospital too. But doctors and other clinical staff aren't included in that same NEO process. So just take a look at your organization, make sure that every NEO has some mention of your language access plan and people know how to access it. Another piece of advice is to start working with those C-suite physicians in your institution too, the chief medical officer, the chief quality and safety officer. Both of them I have on speed dial on my phone, and they help me a lot. Sometimes, you know, when there's a problem with the physician, things seem to get straightened out pretty quickly when it's another doctor talking to them about it. So I would just advise that. You know, at UNM Hospital, we have in-person trainings. We do in-service with people on different units if they're having trouble or they've just hired a lot of new people. I'm sure in a lot of your institutions, there's a lot of travelers, traveling nurses and traveling physicians who are employed there now. And while we're very thankful to have that staff to help us make sure that we provide safe and quality care to our patients, we've got to make sure they know what resources are available to them in our institution. So working with the staffing office to train those traveling providers and nurses is a really good idea too. And similar to what Alida mentioned, we have an online training. So that's good. People can get that reminder. It's a required training every single year. Just to remind them what the services are and how to access them. And then in closing, I'll mention every single leader, whether you're promoted into a leadership position or hired into one, you've got to go through a diversity, equity, and inclusion training. And at the beginning of the presentation, Tim mentioned the departments that are under my umbrella, my responsibility. And everybody learns about those. You know, they learn about what resources we have. And that also sets the tone and the culture of your institution, that this is a part of who you are. And it's not a special service you're just providing out of the kindness of your heart. It is what everybody deserves to have access to communication as they're getting care. Thank you.
Thanks, Fabian. Monica?
I wanted to also make sure to mention that within any training that is developed, to take into account that it's important to educate our staff and providers on how to educate patients on how to access the service and navigate the system. So educate towards your system. Part of that is helping the patient understand the process to access language access, their interpreters, and how to ensure that they know how to really make sure that they're getting the interpreter services, the translation services. So part of the training is for staff to know that it's important for them to let the patient know about the services they have available, how to access them, and to ensure that it's a support that they are readily available to them and how to navigate the system so that it is part of the whole. So it becomes all of us working together for the sake of them. Again, empowering the patient, especially our more vulnerable patients who may be much more uncomfortable advocating for themselves. We want to ensure that they know we are here for them.
Great, thanks, Monica. I know there was in the chat, there was a question about American Sign Language. And, you know, well, don't all deaf people speak American or communicate via American Sign Language? And I know for me, I had very limited access to deaf people when I was growing up. I think I knew one person and only for a couple of years. And so when I took this position about 22 years ago, I was shocked. I thought everyone, like Spanish, the language that I interpret for, used American Sign Language if they were in the United States. But in fact, there's a big variety of needs, communication needs. So American Sign Language interpreters is one way to communicate with deaf patients, but there's also certified deaf interpreters, oral transliterators, CART services, speech reading or lip reading, which is way overused. Most people just figure that everyone can read lips, when in fact it's a very inexact science, and even people who are trained in it in school cannot understand a good percentage of what is presented just by speech reading or lip reading. Why? Well, because people have mustaches, beards that hide the lips, but also they may be from other countries and have strong accents and so forth. So these are things you have to take into account when you're thinking about language access plans and thinking about the services that you need for the patients who come to your facility. And keep in mind that it's not just the patient. We certainly have had cases where the patient, him or herself, is hearing, but the spouse or partner, significant other, or perhaps children are deaf. And we're also responsible to provide services for those family members or friends who are involved in the patient's care or who they would like to be part of the plan for their health care. We've spoken quite a bit kind of about interpreting as we talk about the language access plan, but Monica talked about, and I think Darcy also mentioned the signage and so forth, the document translation. So does someone want to talk about what you have in place for document translation and what the process is that you train staff on how to access document translation? And what do you translate?
I can take on that,
ahead,
and I
Alina.
can share what we do at the health center. So we do have we have seen an increase on document translations and in general in translations. We went from like 1,000 requests, which was very little last year, to 4,300 and something requests this last fiscal year. So we do have a very comprehensive we actually included all this in our policy on how to request translations. We have a specific SharePoint that was created by the manager of interpreter services on how to actually upload a document and the type of formats that we wanted the document in order for us to determine, are we doing this on-site, or are we sending it to the vendor? Who's going to cover the cost of the translation? Is it really necessary for us to translate a medical record that was brought from another country in another language? Do we need to translate the whole thing? Do we only need to translate this? Do we only translate that? So we do a very comprehensive assessment on once we receive documents. The most popular translations that we are doing right now are those on the electronic medical record messages that are being sent by patients. So we do allow patients to send messages to the providers that are taking care of them in the health center in Spanish, Portuguese, and Arabic. And we do translate those. They're very, very small phrases. If it's something that it's it's to top it off and they're not in standard language because everyone just is writing whatever they think at the moment. So we need to make sure that we have translators, qualified translators that are actually able to do that on site. If we can't do, like I said, anything, we send it to the vendor, and then we ask the departments to cover for the cost. But we do, again, have this in our policy. We have all the steps that need to be taken in order for us to receive a translations and for anybody else on the other side to actually submit a translation. Sometimes we get a little bit of pushback as to why do I have to pay for this and why do we create that? And we just send everyone to our policy where everything is written, everything's specified. So there's no doubt about anything. And like I said, we have seen an increase on this. I often get asked also, how does someone get qualified as a translator? We are still looking into that. We haven't created a translator position as of yet. We are on the way of doing that because we see that is really needed. And we have this specific person that was actually helping us doing the translations, taking some trainings, and she's in the road to become certified translator. And eventually we will be able to create a job description and an actual position for that. And that's how we handle translations. We do a lot of patient education materials. At one point, we were also helping, during the pandemic especially, we were helping the marketing department to translate a lot of the important messages that were going through the website. And it's kind of like, let's take the most important thing, whatever we can do in-house, we do it quickly. Usually with there's a turnaround, depending on if it's a electronic medical record message, it takes about 1 to 2 hours the most. If it's something, a document that it's important, we try to do it the same day. But if it's something a little bit more comprehensive, then we usually give them a turnaround time. And we are very good at kind of like keeping track of that.
Great. Thank you, Elida.
Sure.
Fabiana or Monica, do you want to speak about the translation process and how to inform people about it?
Sure. I have something, a brief comment. At UNM Hospital, we have a health literacy department. So typically patient-facing forms like patient-facing education, any kind of registration form, and actually our informed consent for surgeries is now, there's a version in a health literacy approved form, which means that the language is at an 8th grade reading level. So typically what we do is once something has gone through the health literacy office and is at the appropriate English level, then we translate it into the top 15 languages in the state of New Mexico. So that's a good practice, just so that everybody is able to read a document free of jargon, because we know that there's a variety of different education levels. Last thing we want is our patient to be looking at the dictionary to try to read their education information. Similar to Alida, we don't have a translator position in our hospital. We use a vendor for that. One of the supervisors in language services is an ATA, American Translation Association certified translator, and she's working with the team. She's also been a Spanish teacher for a long time, originally from Barcelona, but she's working with our team to learn some techniques. So she's teaching them translation techniques. But it's something that's always a challenge. And I think in our hospital, we cover the costs of all translation documents for the entire system. So it's a budget line.
Great.
Thank you.
Sorry, did you have more, Fabian?
No, that's all. Thank you.
So, so yes, and why are we talking about the details of this? Because this is what has to go into the plan, right? The details about what you provide and how you provide it. Monica, did you want to comment?
Yes, and I want to build on what Fabian just said. Another thing to keep in mind is making sure that clear and simple language to communicate across different health literacy levels is so important. Many of our patients, even our limited English proficient patients, sometimes do turn to our English source documents. Sometimes it is their relatives, sometimes their families who are referencing that. So it is important at so many levels to really consider having that a solid, clear, and simple source document for the benefit of everyone. In addition to that, for us, another thing that we are very much highlighting is the no use of machine translation. Oftentimes people turn to that as a way to breach communication, and though with the best of intentions, not understanding how language works. So part of what we are often trying to mitigate is the use of machine translation. That is increasing. That is an increasing challenge for those of us who are providing language access. But it is important to continue raising awareness that when it comes to machine translation, there is such great risk for our patients' health, and and they're the ones who may have the worst impact. So as we continue developing in-source languages, we need to continue raising awareness of the limitations that machine translation may have. We do use some for our translations. There may be some translation memory that is used, but we always have a human editor looking at documents. As Darcy initially said, very different skill set when it comes to an interpreter and translator, and we want to make sure that people are aware of that and continue raising awareness of the importance of having very solid communications in
Great.
written form.
Thank you, Monica. Yes, and plain language, there used to be a big push on the federal level for plain language documents, and it looks like it's still going on, but perhaps a little bit more quietly. We'll see when the updated Section 1557 comes out, whether there's a mention of that or not. Did you want to comment on that at all, Darcy? Not Section 1557.
Plain language is still very much, yeah, plain language is still very much a thing. It's, as I think most people on the call will understand, there's plain language, and then there's the rules that come out from in statute that have all of the lawyers reviewing it, which is not necessarily as plain language as we would like, but we are always, but when you have, it's that balance of technically correct and to the letter of the law, but also making sure that it is important. I think the other part about plain language is it's everyone benefits from plain language, everyone. So to have that, it doesn't matter if you have a PhD in astrophysics or anything else, plain language benefits everyone. I just saw one of my favorite quotes that came out of the disability community: nothing about us without us. So making sure that community members are always there, giving advice, telling us where we're doing well, telling us where we could do better, pointing out the needs that we have not even yet identified. So all of those things. But yes, no, thank you for letting me jump in there. But Eliada has had her, Eliada.
That's
Alida, I don't know what just happened to my mouth. I apologize. And I'm going to pass it over to you and drink some more water.
No problem. I just wanted to add something that Monica raised, the machine translation, which is very, very important. At a previous institution that I worked at, we did have a very sensitive issue with someone translating something on machine translation a few years ago. And the doctor that actually discovered the mistake did a huge presentation on why it should not be, machine translation should not be used to translate medical terminology, medical letters or anything related to medical stuff. And I was able to include it in our policy. And since we report to that hospital, I was able to bring the same suggestion to the health center, and we have it in our policy. It is actually prohibited that anybody uses machine translation to do any type of health care discussion, being patient education or just a message, a letter, anything. We put it in our policy.
Great, thanks, Alida. And certainly we've been hearing about AI, artificial intelligence, recently, essentially that's what a lot of the translation software is, the automatic computerized translation software. And it's improved quite a bit. But if you're not aware of it, there have been clinical research studies done. And the most recent one was a follow-up to the original. The original was done about 10 years ago, I think. But even just a couple of years ago, there was one done. And there continue to be big problems by having just the computer translate from English into another language. And it's primarily from English into another language. And where, common languages like Spanish, and because of the numbers of actual translations submitted for, to some of the bigger companies about translations have improved quite a bit, they still make big errors that could get you into a lot of trouble. And really, as I use the examples in my trainings for staff, people laugh. And I said, they're funny because they're stupid, right? But if you were the patient or the family member receiving the information saying, your husband had a cardiac arrest, gets translated to your husband's heart was in jail, it doesn't make sense. And you'd be looking quizzically frustrated. What do you mean? Your child is going to be born prematurely. Oh, your child is going to sleep early, right? These are all actual quotes taken from the clinical research. So it's not there yet. I think there is some consideration being considered by the federal government about having machine translation do the first step, but then having a professional translator review and correct any errors that may be in there. We're moving. AI is a very important part of what we're looking towards in the future. And while we may go kicking and screaming, the reality is that there is going to be more room for AI in our world. And so it's important to pay attention to that. I wanted to follow up on one of the things that Elida mentioned that I think the others may have touched on as well with regard to document translation. A couple of things. One is from the federal law from 1964, I believe it was a 3-point evaluation of which documents had to be translated. But the federal government has really moved away from that, and it's really important documents now. And I don't know if Darcy wants to speak to this at all, but the 3-point, discussion about the number of this many people in your area or the type of document, while that's all important, it's not as clean cut as it was, where you could say, oh, I don't have to do that because that doesn't form part of that. Did you want to comment on that at all, Darcy?
Sure, and it's been a minute since I've studied. I think you're referring to the 4-factor analysis.
Right. Sorry.
Which, if I was talking to my OCR colleagues, they would say the 4-factor analysis is not a legal requirement. It is a tool that individuals can use to determine what to translate. And so I think that is still very much the case. I think I've seen kind of the pieces going through on 1557 and where that may end up. So there's different questions there. We have the vital documents versus significant documents. I think, and not to sound like a lawyer, but all the lawyers will always say, because people say, well, what do I have to translate? And unfortunately, for better or for worse, legally, the answer is usually it depends. But, anything that describes your rights, anything that describes how you're going to access the services, all of those things, I think qualify as the essential information that has to be translated. And then I just want to underscore the pieces that folks have said about the machine translation. You have to have human eyes on these pieces, because word for word translation does not cut it. It has to be meaning for meaning, and that so far can only come from humans. Somebody mentioned, well, people use closed captioning. Closed captioning has so many. I've done so many communities of practice where they're like, they'll have closed captioning, and I'll review the transcript afterwards, and I'll say, breadth and depth of a particular topic, and the transcript comes back, or the closed captioning comes back, and it says the birth and death of a topic, and I'm like, whoa, they just had an entirely different experience because breadth and depth and birth and death are night and day. So it's, we have to have those human eyes, because as much as we would like to, save the money or pass it off to someone else, we can't, we're not there yet. Maybe someday, but it's not going to be, it wasn't yesterday, and it's not going to be tomorrow.
Right.
So.
Thanks, Darcy. One of the other things I wanted to pick up was about who pays for document translations in a health system, especially where there are lots of departments and so forth. It may be a little bit different if it's a private clinic or a one clinic place. But that's an important decision, and especially the person in charge of interpreter and translation services should really be a part of that decision. And you may have to take it up the flagpole to the C-suite and talk to the senior leaders. I know that in some of the facilities across the country, every department gets charged. And I know when I started here many years ago, departments would contact us and say, well, how much would this be to translate? And we would give an estimate, and then they would never call us back. And so we changed that process. And while we look like we're sucking up all of the money from the hospital, paying for appropriate document translation, we're in fact saving the health system a lot of money by having it centralized, by paying for it out of the budget of interpreter and translation services. There's no chargebacks. There's no waste of time on charging back to all the hundreds of departments and cost centers that we have. And people are much more willing to get documents translated when they know that they can just simply send an email to us with the document attached, and we have it back to them, depending on what it is, between a few days and a couple of weeks, if it's not urgent. So that's another thing to consider when you're looking at how you're going to set up your document translations and put it into policy and practice, and then include it in the language access plan. One of the things that I know has come up on the chat, and we have included in our questions as well, is as you're preparing a language access plan, how do you include the community? In what ways do you involve the community? Who would like to take that to start with?
If I can add what I just added in, say what I just added in the chats. So I think for us, it's a little bit easier than from a larger organization, because we are a community health care center, and we are very embedded in the community. We attend their events, we support their events. We have quarterly meetings where we have an agenda. They're agenda driven, and we have specific asks. So for example, if we're going to implement a system change, we tell them in advance so they can get feedback from the different services that they provide within the community, and that's typically our patients. We also about 50% of our workforce are part of the community, within the community, the service area that we serve. So that is also very important. And we just kind of like have this back and forth. You help me, I help you, and it's easier for us because we're a community health center, like I said, and we are very, very involved in the community.
Great. Someone want to pick up, Fabian?
Sure. We host a series of listening sessions in the different districts of the county where our hospital is located. Our CEO attends every single one of those sessions. Members from the Board of Trustees attend the session. And we partner with community groups, like similar to what Alita's talking about. Those are our partners, because even though we're the big hospital, we know that we can't do our job without the help of smaller organizations who take care of the same community. So I think having those voices, and also I'm sure if somebody like Elida was in my city and I said, hey, can you help us? We're going to have this session. She could actually bring people more than I could to this session because they know her team, and they trust her. So having a trusted partner in your community will help bring the limited English proficient or people who prefer a language other than English to your listening sessions. And I mentioned in the chat, every single session, language access came up. And we learned a lot that, we have a lot of need for Swahili, for example, in Albuquerque, and Dari, and the different challenges that the Dari or Afghan patients face when they come to the hospital, and people give them a Farsi interpreter. Like, there are challenges with the difference in the language. So, you only learn that unless you partner with the community. One other thing that we've done is there's an organization called United Voices for Newcomer Rights, and they were formed out of the university main campus. And they created this nonprofit. Well, we trained all of their staff who were bilingual in English and the language from the country that they were born in. And they've mostly all have become qualified interpreters. So those people will now be able to partner with the hospital. The hospital can send a steady income to that organization to keep them running, and also pay them for their time. Because it's important that the people providing these services are compensated, because they'll do it for free. I know they will, because they love their community, and as newcomers themselves, they want to make sure that others in that situation have an easier experience. But I think the point I just really want to make, and I'll make it again, is the large institutions have to partner with smaller institutions, because without that partnership, you're missing a lot of valuable information, and patients will fall through the cracks.
Great, Fabian, thank you. And I just wanted to follow up with you. It sounded like the listening sessions were scheduled by the hospital just in general, but that part of what came out of that was about interpreter services. Is there a specific component of the listening sessions that discusses language access, interpreters, document translation, etc.?
We didn't have any scripting, and we just kind of let the conversation go and take place organically. We were prepared with American Sign Language interpreters, Spanish interpreters, and Vietnamese interpreters. But in every single session, it came up. So it just happened organically that people were experiencing that that barrier with language services. And we also had community health workers who brought that up on behalf of the patients who they help navigate the system.
Great. Monica, do you want to say anything about this outreach to the community and how do you get them involved?
Certainly, I think that that also speaks to the different demographics in our healthcare system. Only 4% of our patients are limited English proficient. So we do have a program where we really try to have patient input and advisories, patient advisors to help us understand how we can improve. That being the case, again, thinking about our limited English proficient members are often people who are vulnerable to social determinants of health. And so getting them to provide services, that feedback, sometimes it's a vulnerable place for them to be. You know, complaining about the people who are providing that care may often be a very difficult thing, which goes back to what Fabian and Elida are saying, building that trust. And so while we do partner with community organizations, it is also important to recognize that sometimes we really need to be creative in how to get that feedback. So that's where in our organization here in the Northwest, what we have done is really create ambassadors, which comes through that culturally competent care and unconscious bias, and really helping our champions, you know, advocate for our patients. So oftentimes it is those people who are providing care and seeing the struggles that patients may be having, that they will give me that information, will reach out to the patient, and from that learn what is the barrier, what are the challenges, and then through that engage and get some information that is really important. So really raising that awareness of how can we have staff also be advocates for our patients can also be another way for us to get that information. You have to be creative, because at the end of the day, it's really looking at how we can do performance improvement through different channels of communication that we may get information from.
Wonderful. Thank you very much, Monica. So we've spoken about outreach to the community, and I think we could probably go on for a much longer period of time, but it is such an important topic to make sure that we're hearing from community members, especially, as I mentioned earlier, those groups that may not be coming to your facility. Why is that? Trying to figure that out and going out into the community or working with one of those community organizations to get an inroad into them and insights as to why they're hesitant. What departments do you work with within the facility to kind of publish and get word out about the language access plan and all of its different components? How do you spread the word besides formal training?
I think communications, I think most institutions have internal communication. So making sure that reminders go out at least on a quarterly basis, even just contact information, who the leaders are in the language access departments, how to troubleshoot all those kinds of things, troubleshoot a video machine or a phone interpreter, whatever it may be, when the technology fails us. All of that is very helpful. I also think grand rounds, so that's a good way to reach the physician staff, is, you know, reaching out, and a lot of times the person organizing those sessions is looking for content. So if you reach out to them, now is probably a good time for 2024, and let them know you've got this session that you can provide. I think, you know, and other staff meetings, a lot of times people don't think about it until something goes wrong, and, you know, you've got Department of Health or CMS at your door. Sorry, Darcy, but that happens to us sometimes. And then we're thinking about it, right? But it's great to be prepared before that happens. And the only way to really prepare and prevent errors and in care is to make sure people know how to access the service. So we also have digital boards throughout our hospital, and they're just little screens where our marketing department will create some artwork and design with our logo on it. And those are great reminders. They also help create a sense of belonging to people, you know, as they walk through the halls of the hospital. Your staff feel that, and then also your patient population. So having those run in different languages is good too. QR codes have become really, really helpful. I think a lot of people have smartphones. Everybody almost has a smartphone. And you can scan that and take you to a place where you can read more about what your institution does to meet those needs.
Great, thanks you, Fabian. Anyone else want to comment on that?
In my health center, marketing is my best ally. Marketing goes a long way, and that's why I said at the beginning when we're doing the translations, they asked me for translations, and I was there, even though I was working after hours and stuff like that. I make sure that I have a very strong partnership with them because they are the ones that really help me with the communication, as well as HR, as well in the medical staff office. They're my best partners.
Great, thank you, Elida. And Fabian mentioned internal communications. That means that there's also external communications. And nowadays, a lot of the health centers have web pages and Facebook pages and Twitter feeds and so forth. And do any of your facilities actually have language specific or LEP pages where they have information coming up in different languages for people?
We do, and again, because we have a huge 70% of all the patients that come here are considered to be LEP, so we in all of the social media pages that we conduct, we try to do bilingual messages all the time, and the manager and the supervisor of the marketing department are bilingual, and they actually had to pass the process to make sure that they were completely bilingual. And most of the staff that we hire that are secretaries or like front desk patients, or they are required, medical assistants, they're required to be bilingual because of the huge population that we have. So we do provide everything at least in Spanish and English.
Great. Fabian, it looked like you were going to comment.
I was, and I forgot what I was going to say.
It was about the external communications and Twitter and so forth,
Oh, yes,
or
yes.
X
So,
as they're called now, I guess.
so we haven't done that yet, but we've done a lot with social media over the past years to communicate to the LGBTQIA plus community about services that we provide. And I think that that's a really good partnership to have with marketing, is to create a social media presence around language access. You know, one other thing that we do when patients are in the hospital is we drop off little cards with them that basically remind them of their rights. It reminds the doctor of our responsibility and the nurse for our responsibility to provide those services. So it's a teaching moment, but that's another way we do things internally. But externally, yes, social media, our websites. We're right now working on the DEI website to provide more information to the community. So it's an area of opportunity for UNM Health to get better at, is that external process.
Great, thank you. Monica, anything you want to say?
So I think that where I wanted to also highlight in terms of communications, you know, your compliance and quality departments are really important. You know, from quality, we're looking at the health equity, you know, how can we advance the work in a way that can best serve the patients and reduce those disparities. We're wanting to improve the quality of care and the outcomes. So quality becomes a really important partner in disseminating and advancing the work. And then compliance, you know, which is the other part of, you know, the carrot and the stick. And so really having great partnership with those departments really can help advance the work.
Thank you, Monica. That's actually the comment that I was going to make. That's a huge, huge piece of it. Corporate compliance, risk management, sometimes the hospital lawyers. If you're concerned about something, raise the issue so that others are aware of it. Go ahead, Darcy.
Sure. Yeah, no, I am a strong proponent, and as somebody who's been doing this for 20 plus years, everything in any organization can be made more culturally and linguistically appropriate. And when I used to do this in higher ed, talk about, I said, it's not, you have when you think about your general education courses, you don't go math, check, history, check, cultural competency or culturally linguistically appropriate services, check. We're talking about culturally linguistically appropriate math. We're talking about culturally linguistically appropriate history. And so helping your organization, and each organization culture is going to be a little bit different in terms of who helps sway things or who helps inform things. And if you can bring those individuals along, then you can help, because peer pressure, even as grown-ups, even in our adult organizations, if you're able to say, well, 17 out of 19 of our departments have committed to advancing culturally and linguistically appropriate services. The two that aren't are going to feel some pressure. And depending on how the organization is moving, that can be a real change agent. And then I just wanted to jump back to the social media part, because not only is it an opportunity to do things in a bilingual fashion, but also making sure that we have that alt text, that we have those image descriptions. So for our blind and low vision individuals who are using JAWS or whatever technology to participate in the social media pieces, that they have those pieces as well. So it's always that Venn diagram of language access, communication access, and all of those pieces coming together.
Wonderful, thank you. So let's talk about any challenges that people have had related to a language access plan. Have you experienced any problems? I mean, having one shouldn't be a problem. It's a fair amount of work to actually pull it all together, but it should help guide you. But does anyone have any negative things that have happened as a result of having a language access plan that they're able to discuss or wish to discuss?
I'll mention something, Tim, if that's okay. Here in New Mexico, we are home to 19 different Pueblo communities, the Navajo Nation, and the Apache bands. There are 3 Apache bands in New Mexico. And many of them speak different languages, and many of those languages are only spoken in this part of the world. So one example is the Zuni language, which the Zuni Pueblo speak at the New Mexico-Arizona border. We can't pick up the phone and call HCIN or Language Line and ask for a Zuni English interpreter. So when we have this expectation of our staff, it puts physicians and nurses and medical assistants and everybody who works here in a position to, well, now I know what the language access plan says, but the language services department isn't providing me the resource I need. It's not there. So that was one challenge, and that happens with other languages that aren't so commonly spoken. I think there's a language called Sango from the Central African Republic, and we do have a small community of people who speak Sango. And it's been a challenge for us, to provide that language to people on demand. So anyway, we've had to kind of think outside of the box. We've engaged in conversations with the governor of the Zuni tribe, for example, and started to figure out, are there people working at the Zuni hospital who would be interested in becoming a trained interpreter? And I don't want to seem like a storm cloud of bad news, but then we think about this is a tiny community too. So maybe they don't trust that the person who works at their hospital is going to keep their information private. So everywhere we turn, that it's a challenge. It still makes me happy and proud that we have our language access plan, and we do expect for people to abide by that every time when possible. But we did have to make a different text box in the way that physicians document. Did they at least attempt to get an interpreter? Did they try? And if they couldn't, they can say no interpreter available or something like that. And then I really do believe that it's on the Office of Diversity to find those resources and make them available for people. But that's one challenge of having a really comprehensive language access plan is, you have to have the people to provide the service.
Thanks, and that's such a great example, and we do come across it every once in a while. If you're not in the field, working with one of the national or international telephonic and video companies sounds awesome, and they're going to solve all of your problems, right? Over 200 languages, 24/7. And don't get me wrong, it's an important part of what we all do. But there are those unusual languages and the small groups that speak certain languages. And you do have to think about, one person knowing the whole community's information. And if they're appropriate, a well-trained interpreter, they shouldn't be sharing information. But it is a concern. And probably more so from the patients. If you have a well-trained interpreter, they're not going to discuss things outside of the facility, et cetera. But it's hard in smaller communities when somebody says, oh, so-and-so said they saw you. And it's like, well, why were they there at the hospital, right? It's like, oh, can't talk about that, sorry. So there are challenges there. So thanks for raising that, because yes, we want to make sure that we have as comprehensive a plan as possible so that people understand the services that are available in a centralized place. But we can't solve all of the problems of the world, but we always want to try to make things better and work around, as you say, try to work with a department that will help you find people who can do that. So what are the downsides of not having a language access plan? We kind of said right near the beginning, well, it's not really legally required to have a plan. You have to have the services that are contained in the plan. But how would it benefit you, and how could it perhaps cause problems for you? Anyone want to chime in? Fabian?
I'll take a stab at it.
Sure.
So I think if you don't have a plan, then when the patient is in front of you, people are not going to consistently meet the need. So they won't know what to do. A lot of time will be wasted trying to, how do I connect with an interpreter? What resources are available to us? If you've got a plan and people are educated, they know what to do. They're prepared. It would be just like not having a surgery schedule in the morning or a plan for an operation, right? Nobody would know what to do and everybody would do it a little differently probably. So I think just to standardize the process and make it easy for everybody, it's important just to have that. And I think staff will really appreciate that. Some people appreciate structure and knowing what's expected of them and how to do what they need to do.
Great, thank you. Anyone else want to comment on that? I do notice, I'm not sure why it happened, but the ASL interpreter is now full screen on my end. So I'm not sure if somebody came in a different way, but I still can see all of the panelists. So we're good. We'll continue. Anyone else want to talk about that? Not having a language access plan, the downsides of that. Fabian talked about kind of having it standardized so that everyone understands what they should be doing and what's available to them.
I think that goes back to make it easy to do the right thing. And so that's at the end of the day, what the way I look at my role is how can I support those who are providing care so that they can very easily focus on that care they're providing so that they can meaningfully communicate with their patients. And so by having a plan, you are creating an infrastructure that makes it easy for them to focus on that and not have to really run through the inefficiencies of not knowing what to do in order to breach that communication barrier.
Great, thank you. Now we all have policies, or at least we all should have interpreter and translation services policies that are part of the policy manual for the hospital, now probably online. But this is a little bit more and includes much more. How often should it be updated? Darcy, do you want to touch on that maybe?
Sure, and I think, not to lean into it again, but a little bit of it is going to be, it depends. That's where the needs assessment part of the language access plan that we talked about earlier, knowing who is in your community. Some communities are very, change happens very slowly. And so, you don't necessarily have to survey who is in your community very often. Other communities change very quickly. You know, we saw communities change. One of the initiatives that we have in our office at CMS is translated into, I think it's 8 languages, including English. But we, because of current events, we added Ukrainian earlier this year. And so it's knowing that, okay, we see this change happening, we see this change coming, and so being nimble enough to pivot and be able to expand or contract depending on what your community needs. And I think, Tim, you mentioned earlier, and I think it's just important to remember, it's the community that you're serving, not just the individuals who are coming to your facility, but if you want to put on your business hat or your market share hat, depending on how you operationalize those things, knowing who is in your community and making sure you have services that connect with them and provide them a good experience and allow them to achieve that highest level of health, that's a huge piece. And so, and that in and of itself, we talked earlier about the importance of marketing and those sorts of things. Word of mouth in so many communities is huge. And having a good reputation in your community is a great way. You know, Alida talked about making sure that they're supporting their community, they're attending community events, they are a part of their community. And being seen that way and received that way can be a huge boon to your organization in all sorts of different ways. And I know I've meandered off your actual question, but I feel like it all comes together in the end. But you know, you have to update it as often as it needs to be updated, which is not a concrete answer, but it is one of those pieces. HHS just updated their language access plan. The last time it had been updated was in 2013. So, and there's a whole host of different reasons why it took 10 years to do that update. But so you have to know what your community needs in order to be able to know when you need to update pieces.
Great.
And I see the box is moving around, so I'm going to mute myself and let someone else have a chance to
Thanks,
talk.
Darcy. And I think for those of you who are maybe like, well, how would I know, or what, you know, whatever. Remember, the census is available. It's only every 10 years, but it is available, and that may be kind of formally the only way that some of the smaller communities may be aware of changes. But as Fabian mentioned, if you're working in conjunction with community agencies, as did Elida, you can find out if there are new groups. If you're working with the Refugee and Resettlement Department of your state, you can find out who's being moved to your area or who has moved to your area and you didn't even know it. For bigger cities, the Census Department or the Census, Federal Census actually does have reports that come out and they estimate changes. So you can go there annually for larger cities over a certain population size. So please think about that as well. And we're getting very close to the end. So any quick last comments that anyone may have that they want to make a point of saying? We may have time for a quick question or two. If nobody, Darcy, did you want to make a comment?
Well, I just, thank you for hosting what I think is a very important topic and bringing together these co-panelists, because the wealth and breadth and depth of their experience is huge. And I just want to say thank you to everybody who's on the call for joining us today. Communication, being able to understand what's happening to you at some of your worst times shouldn't be a luxury. If you're getting a difficult diagnosis, if you're a caregiver or the patient yourself, you should be able to understand that in a way that you can comprehend it. So thank you for providing the foundation for that, and I'll let others chime in as well.
Thanks, Darcy. We're just about out of time. So as the moderator, I just want to close in saying that we really thank you, participants, the experience that you all have, and all of you have more than 20 years of experience in the field, and you're really helping out the language access community, not just in the United States, apparently. Canada and Vietnam was on today, and there may have been others as well. But for me, the language access plan, it's a guideline, right? It's pulling it all together. It's really kind of a bow that ties all of the different things that you do that are related into one package. As Fabian said, it centralizes, standardizes, and allows people to access it in one place and not have to look in different places. And if anyone comes to ask you for what you do, it's a very easy thing to be able to either send them the document or hand them a hard copy and say, this is what we do at our facility. And it should be nice and thick so that they see all that we do, because sometimes we don't remember all that we do. And we do a ton to make sure that everyone is able to access the services that we are able to provide through our facilities. So thank you, one and all. I really appreciate the discussion. We've covered a lot of information. I think what we're seeing in the chat is that there's a lot of great information that people are taking away from this, and resources and so forth. And so really, from the National Council on Interpreting in Healthcare, we appreciate your expertise and knowledge and the time that you've taken today to share that with others. And for those of you who have participated today by joining the On the Road webinar, we thank you for your time, and please feel free to stay in touch with us, ask us questions. We will try to follow up as we can with any questions that you may have. CMS is a great place to go to check out the resources that are there. There's a 60-minute, I think it is, training that you can take actually about how to create a language access plan. Thanks, everyone. Have a great day.